Dr. Chattopadhyay.
So, good evening, my dear friends. We are as a third lecture of the series. We have already taken acute kidney injury. We have taken renal replacement therapy. The third lecture is judicious use of fluids in sepsis. Those who are giving European Diploma intensive care, just let me tell you that you will get lots and lots of questions of fluids. We are still undecided on the fluids, as this man was Thomas Atkinson Latta, who basically gave the first intravenous fluid to a patient of cholera in 1832, and that aged female slowly improved, and by the evening time when she improved, and Thomas Atkinson Latta went home satisfied, leaving the patient. So Thomas Atkinson Latta, as I was telling you, in 1832 gave the first fluid through the 𝑭𝒍𝒃𝒂𝒓𝒂𝒃 vein to an elderly woman who was suffering from cholera. And after he became very satisfied that the patient has become all right, he went home to have a nice sleep, leaving the patient on the house surgeon who was looking after the patient. The house surgeon didn't have an iota of knowledge exactly what is going on, and ultimately removed the fluid from the vein, and the patient died by the morning. So that was the first fluid that was given, and the composition of the fluid was homemade, and it was been found later, it was recomposed, it was found it was having sodium of 134, chloride of 118, and a bicarbonate of 16. So fluids, the questions that are always come, that when and why we give fluid, what fluid, how much fluid, when to stop, and what to monitor. These are the basic questions. And we give it for routine maintenance, resuscitation, replacement, redistribution, and reassessment. These are the 5 R's based on which the fluids are given. We'll discuss the resuscitation, the replacement part today. And as we all know, the fluids can be classified into crystalloids and colloids. Crystalloids may be a bit hypertonic in vitro, isotonic in vivo, like normal saline. It may be isotonic or hypotonic. Ring lactate is a bit hypotonic fluid, and there may be hypotonic fluids, severely hypotonic fluids like 5% dextrose, hypertonic fluid like 5% DNS, and there may be ionic or non-ionic fluids like 5% dextrose and non-ionic fluid. Similarly, colloids may be natural colloids or synthetic colloids. Natural colloids, we all know, and synthetic colloids, there's a big controversy with the colloids. We'll come to them later. So we also know the distribution of water inside the body. That is, total body water is 60% for, if it is for males, adult males, around 50% for adult females, 33% is extracellular, 66% is intracellular fluid. Of the extracellular fluid, 25% is interstitial fluid, and 8% is blood or plasma. So you all know all these things. Similarly, when we give crystalloids and colloids, you'll see the colloids will stick inside the plasma for the most of the time, whereas replacement fluids like ring lactate, normal saline, they'll diffuse from the plasma, they'll slowly diffuse into the interstitial space. But now you can see the fluids. Can you see this slide?
Yeah,
When
you
and
can
why,
see the
what,
fluids.
how much, when to stop, and what to monitor.
Yes, sir.
And routine maintenance, resuscitation, replacement, redistribution, and reassessment. We will concentrate on replacement and redistribution. And classification, we have crystalloids and colloids. Crystalloids are hypertonic, isotonic, or hypotonic solutions, ionic and non-ionic solutions. Hypertonic solutions are mainly 5% DNS. In vitro hypertonicity is 0.9% saline, which becomes in vivo isotonic. Isotonic fluids are mainly plasmalites, stereophonics, these are balanced salt solutions. Hypotonic fluid, slight hypotonicity is seen with ring lactate, and marked hypotonicity with 5% dextrose. Colloids may be natural or synthetic. We know about all these things. There were a lot of controversy with colloids. And we come to the distribution of water. We find total body water is 60% for males, 50% for females, 33% is extracellular, 66% intracellular fluid. Of the 33%, 25% is interstitial, and 8% is blood and plasma. We all know about this. And when we give colloids, they mainly stick to the plasma and hardly diffuse to the interstitial fluid and the intercellular fluid. But still, it is not being used nowadays. We'll come to that. Crystalloids or replacement fluids like normal saline, 0.9% saline, ring lactate, balanced salt solutions. From the plasma, they slowly diffuse to the interstitial space, whereas maintenance fluids like 5% dextrose, DNS, they goes from plasma to the interstitial space to the intracellular space. So routine maintenance very quickly. Can you see the slides?
Yes, sir, I
Please
can see.
respond. All right. Routine
Yes.
maintenance, you just see. We use this formula, 4, 2, and 1 formula. 4 ml per hour for the first 10 kgs, 2 ml per hour for the next 10 kgs, and 1 ml per hour for the rest of the weight the patient is having. For example, 50 kg patient, 4 ml for the first 10 kgs is 40 ml, 2 ml for the next 10 kgs is 20 ml, and the remaining is 30 kgs. The 1 ml for the 30 kg is 30 ml. So total is 90 ml per hour. Normally, we give 25 to 30 ml per kg per day of the fluid, which should contain 1 millimole per kg per day of sodium, potassium, chloride, 50 to 100 gram per day of glucose, and we reassess and monitor the patient. And the best of the fluids that can be given is around 0.18% normal saline, 4% glucose, and 20 millimole of potassium. Unfortunately, in India, we don't have this fluid here in our part of the country. We'll get in different parts of Europe. They can ask you the composition of ideal maintenance fluid. So this is the composition of the ideal maintenance fluid. So dextrose, I'll very quickly go through it. Remember, never give dextrose to maintain nutrition of a patient. Hardly, you have to give at least 10 to 12 bottles of dextrose to give that amount of nutrition. That is not possible. Basically, dextrose is used as a maintenance fluid. It is electrolyte free, and it is normally to replace the free water deficit that is present in hypernatremia patient, and used postoperatively as maintenance fluid. If you see that dextrose might cause iatrogenic hyponatremia, hyperglycemia, and is not compatible with blood, might cause hemolysis. So, as we all know, it only 10% stays in the intravascular space, never to be used for resuscitation. DNS contains saline and dextrose. It is basically hyperosmolar, but it goes inside, divides into normal. There is 0.9% saline, and the dextrose part diffuse into the interstitium and the intercellular space. Again, used as a maintenance solution. It is compatible with blood. Remember, again, not to be used for resuscitation. So, resuscitation, replacement, and redistribution. When do we start resuscitation? Normally, if the blood pressure is going down, systolic blood pressure less than 100, heart rate is going up, the capillary refill time, it is basically gaining a lot of importance nowadays after 2021 of this 0.9% saline in cases of traumatic brain injury. So normal saline is normal for patients of traumatic brain injury. So if we go for the buffer to the balanced salt solutions like the plasmalite, the stereofundin, here they use, instead of lactate, they use acetate and malate or gluconate. They also get converted into bicarbonate. Some of them, like the plasmalite, has a SID of 50, quite alkaline. But stereofundin and others might be having a SID of around 28, akin to that of the plasma. So some confusion is there whether this acetate and may decrease the SVR, increase the cardiac output, inotropic action, there is coronary vasodilatation. But these CVS effects are there when you have given a lot of acetates. 85 millimole of acetate over 20 minutes. That means at least in 20 minutes, you have to give 3 to 4 bottles of plasmalite. We normally don't give that. So these apprehensions have been found unfounded. So we go for the guidelines 2016. Now please see these guidelines. They are recommending crystalloids as the fluids of choice for initial resuscitation and subsequent intravascular volume replacement in sepsis. And we suggesting either balanced crystalloids or saline. So recommending crystalloids and suggesting either balanced or saline. Now what happened after that? Already the split trial was going on, and in split trial they compared plasmalite, the balanced salt solution, with saline, and they found that there is no change in incidence of AKI at 90 days. There was no problem. But the salted trial, it is a single center on critically ill patients. Balanced salt was compared with normal saline. Salted was not on critical, it's a non-critically ill patients. It was seen. read it as non-critically ill patients. Questions will come on SALT ED trial and the SMART trial. Single center on non-critically ill patients, balanced salt solution compared with normal saline, no difference in 28 days survival free days or hospital free days, sorry, and the major adverse kidney events make 30 at 30 days with BSS was significantly less than 0.9% saline. So this was the first study you showed that if you use BSS, balanced salt solution, your kidney events are less. This was exactly echoed by this study. This is the SMART trial. It came in 2018 and they found that the major advanced kidney events at 30 days was basically much less, reaching statistical significance in balanced salt solution when compared to normal saline. And the number needed to treat to avoid 1 mEq30 was 94. So based on these two trials, what happened? The SSC guideline came out in 2021 and they told balanced crystalloids instead of normal saline should be used in resuscitating the fluids as a first line agent. Crystalloids are the first line, and in crystalloids it is the balanced instead of normal saline. This was a significant shift from 2016 guideline. And albumin can be used for those who are using large volume of crystalloids. This was there in 2016. And there against starch, there is a strong high quality evidence against starch, and against gelatin it was a weak moderate quality evidence. So this happened in 2021, but your question will be not beyond 2021. What happened after that? After that, we got this trial from Brazil. This is known as the BASICS trial. In ICU resuscitation, they asked two questions. Whether balanced salt solution when compared to 0.9% saline improves 90-day mortality? The answer, simple answer was no. And whether slow infusion, 333 ml per hour compared to first infusion, 999 ml per hour, reduce 90-day mortality? Answer, no. But in traumatic brain injury patients, the 90-day mortality was much higher with normal saline, much higher with balanced salt solution when compared to normal saline. So patients on traumatic brain injury, normal saline was showing lower mortality, reaching statistical significance compared to balanced salt solution. This is so important. This finding was so important in BASICS trial. And on day 3, the CVS at the respiratory SOFA was lower in the slow infusion group. On day 3, the coagulation SOFA was higher in the slow infusion group. They may ask you the question specifically from these trials. They will see whether you have gone through these trials which has come beyond SSC 2021. So another trial came, that is the PLUS trial. And in this trial, they found that when they compared plasma light 148, that is the balanced salt solution, with that of 0.9% saline, whether there was any question was whether there was any decrease in 90-day mortality. Answer was no. So there was no difference in new RRT, receipt of vasoactive drugs, days alive and free of mechanical ventilation, and maximum creatinine level or increase in creatinine. So there is no difference. So now where do we stand? So that is the question that, so they will not ask you which one. If they ask you the question, which one do you prefer? So you have to go over the SSC 21 guidelines, but they will not ask you this question because definitely this guideline is going to be modulated. So now if you have an 80-year-old woman was previously heavy alcoholic, had undergone an abdominal surgery with 3 liters of fluid, is still hypotensive, tachycardic, high VTI, variability, that means the patient is needing fluids, might be needing fluids, mild cognitive impairment, IVC collapsibility was there, and there was low CVP. See, the serum sodium was 142, the chloride is 116, creatinine is 2.5, albumin is 3, mean arterial pressure of 65. But if you can't see the cardiac index, then what you can do? You can do a ABG and you can do a VBG. See the change in PCO2. If the delta PCO2, that is the difference between the VBG the PCO2 level in the VBG minus that in the ABG, that is venous minus arterial PCO2, is more than 6, and your SCVO2 is more than 70 with a normal hematocrit, here dobutamine should be used. Again, there is no advantage of other ionodilators like milrinone or 𝑬𝒑𝒒𝒻 when compared to dobutamine. And this is the fourth statement, very important. Hydrocortisone should be started at least 4 hours after initiation of non-adrenal norepinephrine when the dose is more than 0.25 microgram per kg per minute. So all these 4 statements are absolutely essential, absolutely important in the treatment of sepsis and fluid restitution. So they can give you the trial like this, the question like this is a basics trial because it is the latest one that has come up. It's a multi-center trial. There is a significant 90-day difference in mortality in the BSS group. No, there is no difference. There is no difference in number of AKI patients and patients requiring RRT. Yes. And there is a significant reduction in 90-day mortality in TBI patients receiving BSS. So no, in TBI patients receiving normal saline, there was significant change. Similarly, you can get a question, K-type question, a 6S trial, where you see the first statement is true, that is fluid resuscitation with hydroxyethyl starch as an increased risk of death at 90. I told you the 6S trial has shown not only increased death at 90, but also increase in renal replacement therapy. So A is true, all the others are more or less wrong because the wrong choices have been given. Similarly, the 𝑦𝒂𝒄𝒂𝒓 trial, this is important trial. See, it is a multi-center 2x2 factorial trial, randomly assigning patients with severe sepsis to receive either intensive insulin therapy or on the other hand, you have used 10% pentastarch with ringalactate. And what we have found, rate of hypoglycemia was more in intensive insulin group and increased mortality. No, there was no increase in mortality. The HES group has increased events of renal replacement failure and RRT. So the first one is wrong because there is no increase in mortality. Third one is right. Rate of hypoglycemia was more in intensive insulin group without any increase in mortality. The HES group had an increased incidence of RRT and renal failure. 59% of the patients received colloid prior to randomization, I told you. And the dose limit of HES was exceeded in 10%, at least on day 1, in 100 out of 262 patients. So these are important points on the 𝑦𝒂𝒄𝒂𝒓 trial. So the final one, for example, like the chest trial, the very popular trial. So they might give you this trial. That 90-day mortality in both groups were same in RRT, but RRT was more. So mortality was not changed, RRT was more. Hepatic complications were more in the normal saline group and cardiovascular complication in the hydroxyethyl group. Just the opposite. Hepatic complications were more in the hydroxyethyl group and cardiovascular complication more in the normal saline group. This is very important point. You should note this down. So statistically significant patients suffered from rifle R and rifle RI in the normal saline group. This is also right. And 15% of the patients here received hydroxyethyl starch prior to randomization. This is also right. The SMART trial, because this is the latest one on which the balanced salt solution has been used by the SSC, I give this one. This is the number needed to treat to avoid 1 mEq30 is 94. I told you. It is an unblinded, cluster randomized, multiple crossover RCT. This is another point. Compared to plasma-light A, it compared plasma-light A with ringalactate. This is also true. And the volumes and rates of fluids are predetermined. No, the volumes and rates of fluid were not predetermined. They depended on the monitoring and on the physician. So this type of questions might come. Fluids are very important. You have to, as well as the vasopressors, as well as the dynamic parameters. You have to go through them very carefully. You will get questions everywhere. And I think after this lecture, I hope that I have made many things to you clear. If you have any questions from here, you can go and ask me. Or otherwise, you can anytime contact me on this number. I'll be happy to help you anytime when you need. Thank you so much for your patient hearing.
Thank you, Dr. Chattopadhyay.